Everybody, we're back. Val, are you on?
Yes, I am.
And Ashima? She on?
Yes, hi.
Hi guys. Okay, take it away. You're all set.
Hi, I'm Valerio Cibotaro from University of Maryland. I will co-chair this session with Ashima Gulati from Children's National Hospital in Washington, D.C. Our first speaker is Krista Novak, an associate professor in the Division of Renal Diseases and Hypertension at the University of Colorado Anschutz Medical Center campus. Her research focuses on lifestyle interventions to reduce the risk of cardiovascular disease and kidney disease progression in patients with kidney diseases, including the role of diet and metabolic dysfunction in ADPKD progression. She will be presenting today on targeting adiposity and caloric restriction as strategies to slow progression of ADPKD.
Thank you so much, and thank you to the organizers. I'm really excited to have the chance to talk to you today about our ongoing work on this topic. So I'm going to start at the end here. So this is where we're headed, and I'd like to introduce our most recent project, which is using a GLP-1RA tirzepatide in patients with ADPKD. But before I get there, I want to provide the background over the past about 8 years that led us to this place where we are today. So I'm going to start by talking about evidence that overweight and obesity play a role in ADPKD progression, speak a little bit more specifically about the role of visceral adiposity, and then discuss some ongoing and completed work that we've been doing related to the role of diet, specifically in humans with ADPKD. And then provide a little bit of evidence that based on some pilot work, there is an impairment in kidney oxidative metabolism as well as insulin sensitivity in ADPKD. And then I'll wrap up by introducing our most recent project. So to start off, overweight and obesity in ADPKD. So what's shown on the left here is the prevalence, the average BMI according to decades. And what you can appreciate is that with the passage of time, BMI has been increasing in ADPKD patients. And this is really no different than the general population, which is shown on the right here. And what I'm doing in this figure on the right is comparing the prevalence of overweight and obesity in participants with early stage, represented by HALT A, as well as later stage ADPKD, to data from the CDC, which encompasses the general population. So the take-home message here is that overweight and obesity are common, but this is not unique to ADPKD. This is the state of Western societies. So a number of years ago now, we decided to look at whether overweight or obesity were predictors of ADPKD progression. So we used data from early stage participants with ADPKD from the HALT PKD study and simply divided individuals into categories based on their BMI at baseline. And importantly, we wanted to remove any contributions of organ weight to the classification of BMI. So we subtracted out the approximate weight of the kidneys and the liver and calculated an adjusted BMI in these analyses. And then quite simply, we looked at progression over the about 5-year follow-up period in HALT to look at the change in total kidney volume by MRI, and we also looked at eGFR decline. And what we found was that there was a stepwise increase in annual change in total kidney volume with these increasing categories of BMI. And this association remained strong even when we adjusted for other factors in our multivariate analyses that may have accounted for these associations. We subsequently confirmed that there was a similar association by looking at participants from the Tempo 3/4 tolvaptan trial. So again, what you see on the left here is the stepwise increase in annual kidney growth. And these are, again, relatively early stage ADPKD patients, but at high risk of rapid progression. On the right here, when we used BMI as a predictor, we did not see a difference in the efficacy of tolvaptan according to BMI category, but I will come back to this concept in a few slides here. So in terms of eGFR, we saw a weak association between BMI and eGFR in HALT and no association in Tempo 3/4. However, we had the opportunity recently through collaboration with UCSF to link data from HALT to longer-term outcomes of ESKD and death. So what we did is we were able to look over a longer follow-up period to see, based on baseline BMI, who subsequently progressed to end-stage kidney disease. And the results were quite interesting. Although the event rate is still relatively low in HALT-A, we see a significant association between baseline BMI and progression to this hard endpoint of ESKD. And you see at the bottom here, our fully adjusted hazard ratio, which accounts for other covariates in our model, remains statistically significant. However, in HALT-B, there was no association between BMI and progression to ESKD, which really suggests that other mechanisms may be playing a greater role in later stage disease, and perhaps the time to intervene, so to speak, with regards to adiposity or weight may be earlier on in disease progression. So turning now to the role of specifically visceral adiposity, we all know that body mass index, or BMI, is an imperfect formula to account for how much adiposity an individual may have. People may have different distributions of body fat. And one limitation, if you will, in the collection of MRI images in most PKD trials is that typically we obtain coronal images, and axial images shown on the left are not always obtained in clinical trials. And this was the case in Tempo 3/4. So we were fortunate to have access to all of the baseline images from Tempo 3/4. And given this limitation, we wanted to develop what I'll call a proxy of visceral adiposity using an image from the coronal plane. So what we did is we defined a region of interest approximately 10 pixels above and below the limits of the kidney. And then we quantified the amount of visceral adiposity surrounding the kidneys in the coronal plane. And we saw a really nice correlation using data from our own center that visceral fat had a strong correlation, whether it was calculated in the coronal plane or the axial plane. And additionally, we, working with a company called Aerobics, developed an automated neural network model to determine visceral fat through this automated model. And we saw a really nice correlation between manually segmenting the fat and letting this model do the work for us. So we went on and we applied this model to participants that were in the Tempo 3/4 trial. And although it looks like a lot of information going on in the table in the left here, I want to particularly direct your attention down to this red box here. And the take-home message is that individuals in the highest tertile of visceral fat, based on our model, had a significantly greater risk of rapid kidney growth of at least 7% per year, as compared to those with the lowest reference group of visceral fat. Similarly, we see this increase on the right here as visceral adiposity increases, total kidney volume increases, but The other part I want to draw your attention to is that there appears to be a difference between the placebo and the tolvaptan arm, which I'll come back to. And this is just a box plot that again shows, similar to with BMI, there's a stepwise increase in annual rate of growth. So coming back to the role of tolvaptan, what we see is as we move right on the x-axis, the two lines of tolvaptan and placebo begin to converge on each other. And there was a significant three-way interaction statistically when we looked at treatment time and visceral adiposity. So really what this indicates is that as visceral adiposity increases, tolvaptan has a lesser effect on annual change in total kidney volume. And finally, when we looked only at the individuals who would be classified as normal weight by BMI, we found that higher amount of visceral adiposity was a better predictor of kidney growth as compared to looking just at BMI alone. So changing gears here, I'm going to introduce some of the work that we've been doing specifically on diet. So the first thing that we did was a pilot study where we randomized participants to one of two groups, either a daily caloric restriction diet where calories were asked to be restricted every day of the week by about 34% per day. And we also had an intermittent fasting arm that was given a goal of severe restriction, but every other day of the week. And the net calorie goal was matched across these two arms. And our goal really was to look at the feasibility of doing dietary studies and how people would do in terms of weight loss. And we wanted to look at whether it was safe, acceptable, tolerable, and get some initial insight into whether it might be beneficial. So our design was something like this. We screened people. We included individuals with an eGFR of at least 30, BMI of 25 to 45. We brought them to our clinic for some baseline assessments, and then they were randomized into small groups that were given a curriculum with an education to achieve the dietary goals over a year period. So they met really frequently in this group session, which was taught by a registered dietitian. We kept track of them remotely. We got some additional labs at 3 months, and then we saw them again 1 year later. And all along the way, we were looking to assess feasibility, safety, acceptability, and tolerability. So what we saw in this pilot study is probably not surprising to anybody. What you see on the left group of bars is the adherence score for daily caloric restriction. In the middle is intermittent fasting, and then all groups combined on the right. Over time, diets become more difficult to adhere to, and in particularly, an intermittent fasting diet was much more difficult for people to adhere to long-term. This is somewhat reflected in the change in body weight. We saw that overall weight loss was greater and sustained better with daily caloric restriction compared to intermittent fasting, and this would be considered a clinically significant change in weight. And then in collaboration with Tim Klein at the Mayo Clinic, we also looked at changes specifically in visceral adiposity. So again, you see here the axial plane. And just to increase power, I'm showing pooled groups. And what you see is a reduction in subcutaneous, visceral, and total adiposity tissue at the end of the 12-month period. It was simply an exploratory aim to look and change in total kidney volume, but I'm showing here on the left the baseline and end of study height-adjusted total kidney volume in each of the two groups. You can see that the annual percent change was relatively low in comparison to what we might have expected historically. So I put this into context on the right by comparing our annual percent change to some other observational and interventional cohorts, including CRISP, the HALT studies, Tempo 3-4, and DIPAC. So we were encouraged by these results. Very interestingly to us, it seemed to be less so about what group someone was placed in and more about how much weight individuals lost. And we saw a very strong correlation between the amount of weight loss and annual change in total kidney volume, such that those individuals who successfully lost weight had negligible change or even a negative value in terms of change in total kidney volume. And we saw a similar association when we plotted change in visceral adiposity against change in total kidney volume. So we put this all together in one large paper, and I'm not presenting the data today due to time, but my colleague Katarina Hopp also looked at some of these interventions in the PKD RCRC model and found very similar results to our human study in that the mice who were placed on daily caloric restriction were the only group that had a change in weight and the only group that had a change in PKD severity at the end of the study, which really paralleled the fact that we saw a change that was greater in weight with daily caloric restriction and that this correlated strongly with change in total kidney volume. So all of this led to a phase 2 study that is almost fully enrolled. It's been going on for a little while now, where we are looking instead of feasibility at the efficacy of daily caloric restriction. So we decided to focus on this group or this particular intervention based on the fact that in our pilot study, the caloric restriction group overall had better success with the diet, better adherence, and better tolerability. And we seemed to observe a similar signal for efficacy as compared to intermittent fasting. So this group is quite similar to in the pilot study. However, it is now a 2-year study. And then we have a standard advice control group, which basically gets the advice in a one-time session to restrict the amount of calories that they're eating, but they don't have sustained support over the 2-year period. So our primary outcome in this trial is to look at change in total kidney volume by MRI at 2 years. And we're also quantifying changes in abdominal adiposity and looking mechanistically at different markers, including subcutaneous fat biopsies that we are obtaining. And of course, we're continuing to look at safety. So this design looks quite similar to the pilot that I just showed you, but our main outcomes are shown here. And we have random assignment of a larger cohort in this particular study. And we are almost fully enrolled. We will be enrolling our last cohort this June. So if you know of any patients that might be interested in this study, this will be the last chance in June to join a cohort for the study. We've had a number of cohorts that have already finished. And then at 2 years, participants are coming back to have these measurements repeated. So quick segue into some work that was done by my colleague, Dr. Bjornstad, who recently moved to University of Washington, where he looked at kidney oxidative metabolism in ADPKD. And this methodology was also done in collaboration with Tim Klein. And what you see on the left is Dr. Klein's work to integrate MRI. So you can see in A, individual cyst segmentation, as well as in C and D, liver and kidney segmentation. And we integrated this with PET CT scans shown on the right. So this PET CT methodology uses an 11C acetate tracer to look at turnover in the TCA cycle. So it is a measure of kidney oxidative metabolism. And on the top right, you see ADPKD representative images, whereas on the bottom is normal weight control. And you can see an attenuation of kidney oxidative metabolism. So this is summed up pretty nicely in this graphical abstract from the publication. So relatively small pilot study. These are expensive and lengthy measurements to perform. You can get a flavor of the participants on the left here. Main take-home messages was that in addition to the method I introduced on the last slide, we did the gold standard of clamps to look at insulin sensitivity, and after adjusting for differences in lean mass, the ADPKD patients demonstrated a impairment in insulin sensitivity that's shown by the M to I ratio. There was less cortical perfusion as well as less oxidative metabolism. And we saw correlations with height adjusted total kidney volume with each of these parameters. So taking together all of the evidence that I've shown so far, this led us to our most recent project where we are looking at the potential of glucagon-like peptide-1 receptor agonists, or GLP-1RAs, in ADPKD. So most of you are probably familiar with this class of medications that have gotten a lot of attention lately for the weight loss that they promote. So these agonists act in addition to affecting insulin secretion. They affect the brain in terms of things such as appetite. They have effects on the liver, effects on energy consumption, and effects on the stomach in terms of gastric emptying. And the more recent class of these medications are dual agents. So in addition to targeting GLP-1, there are agents that also target glucose-dependent insulinotropic polypeptide, or GIP. And this combined action on GIP and GLP-1
5 minutes remaining.
leads to an accentuated incretin effect. So medications such as tirzepatide, which we are focusing on, have even greater effects in terms of body weight and body glucose than the earlier generations of medications such as semaglutide. So our working hypothesis that we are currently testing is that administration of tirzepatide as a GLP-1RA will lead to slowed cyst expansion and kidney growth, and that this will be due in part due to weight loss, but also specifically through changes in central adiposity, changes in insulin resistance, inflammation, and in a subgroup of participants, we'll be looking at changes in kidney metabolism. So our design is outlined in this figure here. So this is a randomized double-blind parallel group trial. It is 12 months in duration. We will be giving once weekly injections after a titration period. The dose will be 5 milligrams per week. And the goal is to primarily look at change in total kidney volume as a primary outcome. And we are additionally looking at changes in abdominal adiposity by MRI. We will look at some markers to get at changes in adipokines, inflammatory markers, and in a subset of participants, we will be doing the PET-CT imaging to look at changes in kidney oxidative metabolism. This has been a very challenging study to get off the ground, and I can talk a little bit more about how we got to where we are with this study, which was a little bit different from our original vision for the trial, but we're excited to get started, and we'll be randomizing our first participants actually this month. So with that, I did not list the many, many people who have contributed to this work. Appreciate all of the great collaborators in the funding sources, and happy to take questions.
Great presentation. I have a question. Is there a target or optimal BMI for ADPKD patients? For example, if someone has a BMI of 20, would you still recommend caloric restrictions? And the second question, in most of your studies, you look at total kidney volume. Are you planning to look at renal function as well? Thank you.
Thank you. So first question regarding ideal body weight. The short answer is I don't think we know exactly. We've just grouped everybody in that normal BMI category to date, without really trying to stratify even further. My sense is that if someone's at a BMI of 20, I don't think recommending caloric restriction would make much sense. In most of our studies, we have excluded individuals who have a BMI that would put them into the underweight category, simply because the N for those analyses typically is pretty low, which makes it really difficult to draw conclusions. And there may be other reasons why you're seeing low BMI in certain individuals. It may be an index of maybe other comorbidities contributing to a frail state, so to speak. And then sorry, what was your second question again?
Are you planning to look at kidney function besides the total kidney volume?
Function. The answer is yes. We are looking at estimated GFR in all of our ongoing studies, but we are not looking at any measured GFR.
So, Martin Prince asked, your images show measurement of perirenal fat. How are you defining visceral fat? Is the automatic visceral fat measuring tool available?
So how are we measuring it? Based on like radiologists' knowledge of where the visceral fat is by MRI imaging. I would say if you're interested, reach out to Tim Klein. I'm sure he would be happy to chat more about the methods that he's developed. We've also deposited our code that can be requested. The details are in our iScience paper as to how to access that.
Question from Arlene Chapman. Great presentation. Do you have genotypes on these individuals to determine if PKD2 versus PKD1 individuals are differently impacted by caloric restriction?
So the short answer is yes, we are getting that information in our ongoing trial. It is an optional consent, so we probably are missing it in a few people, but most people do opt in to the genotyping. We have not yet looked in the current study because it's ongoing and we didn't have enough people in the pilot study to look at the role of genotype, but we will be able to at the conclusion of our larger trial.
Okay. Question from Taka Saigusa. Have you looked at how much exercise was involved in the CR, fasting and control participants?
Thank you for that question. And I kind of glossed over this because of time, but all participants were in the pilot and in the current study are encouraged to increase physical activity. And that's really important because exercise and diet, as we know, go hand in hand. And in particular, with a 2-year study, in year 2, it's important to maintain a high level of physical activity in this maintenance phase, so to speak, so that weight regain doesn't occur. So we are advising to increase physical activity, and we are getting quantitative measures of physical activity as best you can by using accelerometers, which we have participants wear. So we will have data on physical activity. We did not use the accelerometers in the pilot study. We just used questionnaires, but that was just due to cost at the time of the pilot.
Question from Anu. Is there a rationale for using BMI instead of waist measurement for assessment, given that waist measurement is a better predictor of fat distribution?
I think the complicated part about using waist in PKD patients is sometimes waist is larger due to the size of the kidneys. I mean, maybe you could come up with some other kind of formula that you take out the effect of the kidneys, similar to what we did with weight, but I think it becomes a little bit of a challenging measure, specifically in PKD, because of the possibility of distended abdomens due to organ volume.
Question from Lisa Quay Woodford. I'm curious about the low dose of tirzepatide in your most recent study. Are you sure that you will have a therapeutic effect?
So it's always a good question. Which dose should you pick? We thought long and hard about this. And I think that the dose that we picked will still have clinically significant weight loss based on studies to date. We wanted to balance the potential GI effects, side effects with higher doses that might cause participants to drop out or not be able to tolerate the drug, or maybe to get themselves into trouble with AKI risk, etc. So I feel good about the final dose that we ended up picking as a starting point, but the point is well taken that there is a range of different doses that could have been considered.
One more question from Terry Watnick. Is there a BMI target for inclusion in the terzepatide study?
Oh, thank you. I glossed over that. So it's 27, which is really the FDA labeling for tirzepatide.
Okay, there are two more questions. Could you please answer them in the chat? We'll move to next speaker.
Will do. Thank you.
Thank you.
All right. Good afternoon. It's a pleasure to introduce our second speaker for this session, Dr. Arlene Chapman, who is well known to the PKD community. Dr. Chapman is a professor of medicine and chief of nephrology at the University of Chicago, where she directs the PKD Centers of Excellence. Her research and clinical efforts are focused on the physiology and management of patients with ADPKD. Dr. Chapman will be talking on an important understudied area, that is health disparities in the management of autosomal dominant PKD in the US. I invite Dr. Chapman.
Thank you so much for the lovely introduction. Now, do I share my slides or does Kristen take her slides down?
Yeah, Kristen, you have to unshare yours. There we go.
Okay. One sec. I don't want to go into my time too much, or else I'll be Adrian Brody by the end of this. Hold on. Okay. Is that okay for everyone to see?
Yes.
Okay. So I have no disclosures pertinent to this talk today, and I think it's fair to say this is a timely topic, given the current state of affairs. And I can share with everyone that this is work that has been done internally at the University of Chicago without any funding whatsoever. So there's some background slides here that will be familiar to everyone, but there are some that are important in the context of the work that's going to be presented. And so PKD is the fourth leading cause of renal failure in the United States. And what's really important here is there's no racial predilection for who gets ADPKD. There are over 3 million individuals diagnosed worldwide, and although oftentimes is referred to as adult, this disease begins at the time of conception. The incidence, prevalence, and survival rates, and even the age of onset of renal failure are increasing in the United States. There are between 6.1 and 7.5 new cases of kidney failure due to PKD per million people in the US, and there are slightly more men than women who meet this criteria. And PKD represents about 6% of all patients receiving renal replacement therapy. And if we look at individuals under the age of 65, it's about 10% of the end-stage kidney disease population. So there was some very nice work done by Dr. Karnek-Legal looking at the impact of genotype on the age of onset of renal failure. And it's been known now for quite some time that individuals who have PKD2 mutations tend to have milder disease, start dialysis about 20 years later than their PKD1 counterparts, live longer, develop complications such as hypertension later. But in that setting, there are cases where intrafamilial variability is present with regard to disease progression. There's a significant variability within families with the age of onset of renal failure. And this begs the question of whether or not there may be either genetic modifier effects or potentially environmental factors that contribute to the differences within families. So the question was raised whether or not racial and ethnic disparities exist in PKD care and outcomes. And as I think everyone here would agree, race is a social construct, and PKD is a genetic biological disorder. And In background to this, this is work done by a Department of Surgery team, Dr. Murphy and colleagues, looking at the mean age of onset of renal failure in African American versus white ADPKD individuals. And the y-axis is a little bit compressed here, but it certainly shows that there is a slightly younger age of onset of renal failure in African American individuals compared to their Caucasian counterparts. So our aim was to study what factors might influence care and outcomes in PKD and focusing on national trends. We initially started with Cook County because it's here in Chicago, and also there's been an awful lot of data published about different life expectancies depending on where you live in the city of Chicago. And so we wanted to look at age of onset of renal failure and care leading up to the initiation of renal replacement therapy. And we also wanted to look at access to kidney transplantation, both preemptively and with regard to quality kidney scores at the time of transplant. So here's a map of Cook County. We chose patients who had on their USRDS diagnosis page ADPKD, but they also had to be older than 30 years of age. We wanted to make sure we had as accurate a diagnosis of ADPKD as possible. And we were fortunate enough to have data to evaluate between the year 2000 and the year 2018. And I must say, none of this work could have been done without the help of a really talented nephrologist in our section, Rita McGill, who came to us from Tufts after finishing her master's, and she really has done just yeoman's work in this project. So we divided our study populations into 3 categories of self-identified race: African American, Hispanic, white, and others. Asian American, Indian, Alaskan Native, Native Hawaiian, and Pacific Islander were considered our other group. And linear regression analysis was used to evaluate the age of onset of end-stage kidney disease. Logistic regression was used to evaluate access to preemptive kidney transplant, and Cox models were developed to evaluate rates of kidney transplantation after starting dialysis. And our multivariable analysis had adjustments made for gender, insurance status, employment status, serum albumin, and hemoglobin. So this gives you an idea of the makeup of the populations both in the US and in Cook County. You can see that Cook County is slightly more racially diverse, with 28% being African American, 14% being Hispanic, and about 57% being white or other. And here we can see each of the variables without adjustment. So you can see that whites are on the right-hand column. They have the latest age of onset of renal replacement therapy. They are less likely to get hemodialysis compared to African Americans and Hispanics. They are more likely to have a preemptive transplant. And they are equivalent to Hispanics in ever getting a kidney transplant, but close to twice as likely to get a kidney transplant compared to African Americans. More likely to have private insurance, more likely to be employed 6 months prior or at the time of renal failure onset. And some of the clinical variables such as estimated GFR, hemoglobin, use of erythropoietin and albumin levels are shown here and really didn't contribute too much to the differences seen across race. So here we have the probability of getting a kidney transplant after starting dialysis. So the lower the curve, the better, right? And so you can see here that white patients are more likely to get a transplant after initiating dialysis than their Hispanic and their African American counterparts. So in Cook County, compared to white patients, African American patients start renal replacement therapy about 4.2 years earlier. They're 69% less likely to get a preemptive kidney transplant, and they're 49% less likely to get any kidney transplant. Hispanic patients reach kidney failure even earlier than African American individuals, 5.9 years earlier. And their rates of kidney transplant are intermediate between whites and African American ADPKD individuals. So, Cook County is quite diverse, and we weren't sure that we would see the same trends across the country. So we expanded this analysis to investigate whether or not disparities exist across the country. And you can see here between the year 2000 and 2018, there were approximately 44,000 individuals with ADPKD receiving renal replacement therapy. There were a small number where we didn't have data available for gender, race, ethnicity, or outcome. And then we subtracted out the Cook County individuals because those were already analyzed. So in the US, when adjusting for gender, insurance status, employment status, albumin, and hemoglobin, African American patients reach renal failure 2.3 years earlier than white patients, and Hispanic patients reach kidney failure 4.4 years earlier than white patients. And you can see both the univariate and the multivariate analyses here, showing also that employment status plays a significant role, serum albumin levels play a significant role, and to a lesser extent, having private insurance plays a significant role. So what about a preemptive kidney transplant? Again, adjusting for multiple variables, African American patients are 68% less likely, and Hispanic patients are 54% less likely to receive a preemptive kidney transplant compared to their white counterparts. And I'm going to show you data in a minute looking at PKD versus non-PKD patients. PKD patients overall actually do a lot better than patients without PKD. And again, private insurance plays a significant role here, as does employment status and markers of stability measured by serum albumin and hemoglobin. So what about after dialysis? Again, adjusting for the variables that could play a role, the rates of receiving any kidney transplant are 45% lower in African American ADPKD patients and 27% lower in Hispanic ADPKD patients. And the same variables that were associated with preemptive transplant and age of onset of renal failure continue to contribute to these differences seen. So here is the countrywide chances of getting a transplant post initiation of renal replacement therapy. Again, the lower the curve, the better. And you can see that there is a significant difference between whites and non-white ADPKD individuals. So we were able to go into the ESRD networks because there's significant heterogeneity throughout the country in terms of proportions of patients who are African American, Hispanic, and white. And for wherever you're from, you can see here what your distribution of end-stage kidney disease patients are with ADPKD. And in Illinois, where I am, it's 76% white, 8.2% Hispanic, and 15.4% African American. And this shows in African Americans whether or not the odds of getting a preemptive transplant are compared to whites. So there's significant geographical variability in the reduced rate of preemptive transplantation. And again, this is Illinois here. We're at about a 23% likelihood of an African American ADPKD patient getting a preemptive kidney transplant compared to a white individual. I'll toggle back and forth in just a minute because the next shows the Hispanic rates. And it's quite interesting when you look at different parts of the country that Hispanic patients could do worse than this or much, much better depending on where they are. So here are the Hispanic relative likelihoods of getting a preemptive kidney transplant. And you can see in the north, in the Midwest, they're actually not too bad. There are areas in the Southeast where there just aren't enough Hispanic patients getting preemptive kidney transplants to be able to calculate the likelihood of its comparison to whites. So if we look at this by network now, you can see whether you're African American or Hispanic, your likelihood of getting a transplant is less than that of whites, and the chances of it go down from top to bottom. They've been rank ordered from the best to the worst. And the confidence intervals for the Hispanic patients are quite large, in part due to their lower numbers. So it's difficult to interpret some of the results from these individuals. So this is just a summary of what I've shown you. This is the visual abstract. It was a retrospective cohort study. The number of patients left to analyze were over 41,000. They had a median follow-up of just over 2 years. You can see the distribution of patients across the country, and you can see what the chances were of African American or Hispanic patients receiving a preemptive transplant or receiving a transplant at all after starting dialysis. So whether in Cook County or in the US, if a PKD patient is a minority, if he doesn't have private insurance, they are not employed at the time of dialysis, or if they live within a certain region, or if they're burdened by health factors measured as surrogates by serum albumin or hemoglobin, and particularly if they're male and African American, really impacts their age of onset of renal failure, their access to kidney transplant, and their rate of kidney transplant over time. And exploring factors will help provide a better understanding and explanation for these disparities, and perhaps some insight into how to reduce them. So in the US, African Americans have a 2-year and Hispanics 4 to 5 year earlier onset of renal failure compared to white patients. Access to preemptive kidney transplant is lower in both African Americans and Hispanics, and this varies significantly by geographic region. And the rates of transplant after initiation of dialysis are lower for both African American and Hispanic ADPKD patients. And African American men experience the slowest rate of kidney transplantation across all groups. So what are the things that could be done? Laws permitting the initiation of Medicare coverage once a PKD patient is eligible to be evaluated for kidney transplant might help. Increasing and earlier education about living donation by nephrologists to PKD patients and their families. Increased outreach for living donations, and initiatives to improve access to kidney care, and communication and support resources to PKD patients with social workers once starting end-stage kidney disease. And I think really targeting these areas could provide fertile ground for determining how to improve the disparities that we see. So I'm going to finish up talking a little bit about transplantation, right? And so although the disparity for graft loss has significantly improved, there are still some equity issues and other disparities. And this really is targeted by some of the things I've already shown you, which is the living donation rates, but also delayed graft function rates. And you can see on the right-hand side here, there's a significant difference in the 5-year graft loss rates in African Americans, which are in red, versus Caucasians, which are in blue. And so whether or not this is related to the quality of the kidney organ donated, or if there are other compliance issues associated with this, it's really not clear what the contributing factors are for this. So this is another very nice observational cohort study done on Kaiser Permanente patients in Southern California. And they had the opportunity to look at close to 4,000 individuals. And I just want you to focus over on the right-hand side for a minute because we're focusing on transplant. And you can see that, again, African Americans are less likely to get kidney transplants, very unlikely to get a preemptive kidney transplant. And these are all PKD patients. So when we talk about donor pools being reduced in PKD because of the hereditary nature of the disease, each of these different groups of patients are facing the same issue. So the impact of estimated post-transplant survival scores on transplant in ADPKD patients could be playing a role here. And access to kidney transplant and post-transplant outcomes are impacted by race. And these EPTS scores are used to allocate high longevity kidneys to patients who are expected to receive the most years of graft function. So what we did was we examined the EPTS scores in PKD patients and compared them to results to transplant recipients with other kidney disease. So to go over the contributors to the EPTS scores: age, length of time on dialysis, whether or not someone's had a previous transplant, and this can be of any organ, and if there's a presence of diabetes, all contribute to the EPTS scores. And the range for an EPTS score is anywhere from 0 to 100%. Those who have lower scores are expected to experience more years of graft function from high longevity kidneys compared to candidates with high EPTS scores. And that data is shown here from OPTN data in 2020. And you can see that the 0 to 20% group had a much longer patient survival rate than those with the 81 to 100%. Now, for all practicality, the scores are bisected so that they're either less than 20% or they're more than 20%, which then determines prioritization for a high level kidney. So the EPTS score is used in tandem with the kidney donor profile index, which is the quality of the donated kidney. The EPTS score is used when the donor has KDPI less than 20%. And so we don't see the EPTS scores used in a number of kidneys. Patients with EPTS scores less than 20% are those who are prioritized. And there are groups that rank order the allocation, and it takes into account how long they've been on the waiting list, their HLA-DR matching, pediatric status, and a couple of other factors. So if we look at the higher EPTS scores and the consequences, non-whites, especially African Americans, are inadvertently pushed into the greater than 20% EPTS score. Therefore, they fail to receive a less than 20% KDPI category kidney, and greater 20% KDPI kidneys have lower graft survival compared to those with less than 20%. So here are the kidney donor kidney alone transplants from 2008 to 2018 based on their KDPI score.
5 minutes remaining.
Okay, thank you. Those with the less than 20% score do better than those with the higher KDPI scores. So here is the AD-PKD and non-PKD patients older than 30 years old who got a transplant between the year 2000 and 2021, taken from our OPTN UNOS data, where ethnicity was unambiguously identified as white, African American, Hispanic, and the 4 components of the EPTS score were analyzed by race for both groups. And I'm going to skip over the calculations for the interest of time. And so here you see on the top are the PKD patients, and on the bottom are the non-PKD patients. So first off, what you can see is that whites typically have more likely to have a less than 20% EPTS score in both groups, but PKD patients overall do much better than non-PKD patients. And I think that's important to note. The other thing that's important to note is that it's really the duration of dialysis that shows up as being quite different in African Americans compared to non-African Americans. If we look at the post-transplant score at the time of transplant, not at the time of listing, you can see again that AD-PKD individuals do much better than non-AD-PKD individuals. But by the time someone's transplanted, the scores have gone down. And you can also see that the duration of dialysis is the highest in African American individuals. And then finally, this is where this probably makes the biggest difference, is when we only look at the deceased donor kidney transplant patients. By and large, all groups have dropped down so that no one is above 30% for an EPTS score less than 20%. And again, the duration on dialysis is significantly greater in both African Americans and Hispanics compared to others. So transplant recipients with EPTS scores less than 20% heavily favor Caucasian recipients. And so why are the EPTS scores greater in the non-white population? Of all factors, the duration of dialysis was the determining factor for the higher EPTS scores. But racial disparity exists at every stage of the transplant process, including time from starting dialysis to kidney transplant waitlisting. And African American and Hispanic patients have significantly longer times from starting dialysis to waitlisting. So it really is a double-edged sword. There are higher allocation points the longer you're on dialysis, but you also have a higher EPTS score. So this is a single center multivariable analysis of 1,900 patients waitlisted for kidney transplant between 2005 and 2010. And African American race was associated with significantly longer median time from starting dialysis to waitlisting in both univariate and multivariate analyses. And these were the variables that were found to impact that time. A higher BMI, kidney alone versus kidney and pancreas transplants, lower annual household income, and Medicare or Medicaid versus private or self-insurance. So there's lots of ways to help reduce these disparities, and I think all of us are well aware of these. But just to remind everyone, there are socioeconomic and environmental disparities. There certainly is an issue now in terms of racial ancestry and access to living donors. Insurance is associated significantly with the ability to get a living donor. Poor access to timely donation, which is what I just mentioned, and lack of transplant education for rates of referrals. So in conclusion, transplanted patients had lower EPTS scores. There was a reduced access to transplant with increasing dialysis time among non-white patients with ADPKD. It certainly magnifies the disparity by reducing allocation of the best quality kidneys to minority patients with ADPKD. And on a positive note, to adjust for the prior overestimation of estimated GFR with estimating equations, now African Americans who have creatinine data can start their waitlist time from the time of their GFR being less than 20 ml per minute. So I'd like to thank you, and a real special thanks to Alex Hayward, who is our student who did her thesis on this, and Doctors Rita McGill, Milda Saunders, and our Living Donor Program Associate. Thank you.
Thank you, Dr. Chapman, for that great talk on a typically very much under-addressed area. I will start with a question. Can you comment on the potential contribution of APOL1 and sickle cell trait-related genetic polymorphisms that may be co-occurring in a very small subset, perhaps, of patients with ADPKD? And is there an effort, is there a move to address some of those issues in this cohort or other cohorts?
Yeah, so, there have been a couple of studies that are quite old now that had looked at sickle cell disease and outcomes in African American ADPKD patients. It was done in Tennessee, I think. And I don't think that they showed that there was that much of a difference. It was a very, very small study. And as far as APOL1 disease goes, at least now at the time of evaluation for potential donors and also in the recipient, genetic testing is becoming more and more common. So it is playing a role in the transplantation process. But whether or not either one of those modifies disease severity hasn't systematically been studied.